The other numbers that came out of this in that highlighted red area is acutely, if there's an aortic enlargement to more than 40 millimeters, that's an indication because it's going to continue to get bigger. And then other data that looked at this from University of Pennsylvania on that top row, this is not a randomized trial, but when you look at open surgery, in their case, with a mortality rate somewhere around 40% compared to medical management, similarly, or to the TVAR patients down around 4. Again, it emphasizes that ability to dramatically reduce not only the acute mortality rate compared to surgery, but also to deal with the paraplegia. These are the comparison of those two lines. The other thing that convinced everybody was the INSTEAD trial. This we all initially thought was an acute trial. It turned out it was chronic patients between 14 days and a year. But in a comparison of 70 with endografts and 60 with best medical management, it turned out at 2 years there was no difference, but at 5 years there was about 40% crossover from the medical group to an interventional group. So it really then is data that's helped support it in many of our minds that even in the chronics now. So what we want to try to do is treat them earlier, avoid that chronic phase, but if you have to, then look at that infrarenal enlargement so that regression occurs, but it's persistent with that visceral flow. And this is just an example of what it looks like when you put a graft in, but the infrarenal segment gets bigger. Fenestrated solutions, potentially the multi-layer stents for this, but really at the current time for asymptomatic patients or even those with, and particularly those with malperfusion, this early intervention we favor.